Waiting for a train to leave to London. This isn't it, Beth? You've got to just count down. Okay. So it's now 10 o'clock and um, we're going to start this morning. So a really big welcome to everyone joining us today. We've got, I'm counting 91 participants at the moment, which is fantastic. And it'll hopefully increase because other people are sort of coming to the meeting and fitting in amongst other things we've got to do. So if I introduce myself, my name's Neil Fothergill. I'm a clinical advisor with the Northwest Coast Clinical Network. And this summit's been organised by the Northwest Coast Clinical Network, which is part of NHS England and Improvement. So what I'm going to do firstly is housekeeping. So again, these meetings are fantastic, but we always need to sort of remind them, because especially with so many people. So if you please turn off your microphone and your camera. The event's being filmed, so hopefully people are fine about that, because it's important to be able to disseminate it. But afterwards, the slides and the recording will be shared. What we'd really like today is, especially because there's so many people from across the region, we'd like people to contribute your thoughts and ideas. Especially because you can use the chat, you can use, and we're going to be using Mentimeter, which people have hopefully got a handle on. Okay. And when you put things in chat, people will be picking up on them, maybe not immediately, but later on as we have summaries. Okay. So, and the main thing is, about getting involved in the day. This is part of an event that's getting conversations going and getting people going and trying to develop links between people. So if you're new to Mentimeter, you open it on your browser, open on your smartphone. If you look on the screen, there's a QR code, or go to the menti.com. I use my smartphone when I'm using this because it's just a bit easier, okay? And then there's a code, you put the code in, and then hopefully that'll take you to the site you need to be in. So during the day's meeting, you'll be going to there and they'll be asking some open-ended questions, but and also submit questions, okay? So in terms of what I'm going to do is set the scene. From future in mind and long-term plan and 5-year forward view, we've been trying to transform mental health services and well-being services for children, infants, young people and adults. And part of the work of this network has been looking at services for children and young people with mental health problems, but also perinatal mental health services. So more recently, there's been an initiative to try and look at a bigger offer from 0 to 25. So when we started looking at that, what we suddenly realized was we tried to take stock of where we were starting from, and there's a fragmented service. So if you just think about where you're from, your service, and all the people that you actually link in with in part of your job. So today there's people from social care, there's people from healthcare, people from education, people from the voluntary or third sector. So there was lots of sort of partners and stakeholders. Also, we were conscious there was lots of groups working on developing. Some of those were local, some of those were across the region. And as usual, we often use this word silo working and thinking about, are we sometimes all guilty of working from our narrow viewpoint? So I work in an NHS service and a CAMS team, and I often worry that I see things through my lens. So we were really, really conscious of doing some work like this, okay? There was also some really good work by the Parent-Infant Relationship Partnership Group, which developed a pathway tool. So again, there was bits of work which were going really well and had lots of involvement and buy-in. So back in November, which seems ages ago, that would have been, I'm not sure it was 2020 or I think it was 21. Beth can correct me there. So about 21, there was a scoping of services. And what we did was we sent out a questionnaire to commissioners in each area. We got a decent response rate of the CCG areas from 56%. And just some outline findings from that work. So firstly, as you can expect, we had a huge variation in what the offer, both in terms of the range of offer and the capacity. That we identified 5 specialist services who were offering mental health services to children under 5 years. And also there was 3 new services in development. If I just go on to the next slide, there's a diagram we can hopefully look through. Yeah. So if we just have a quick look at this. So this was looking at the idea on the left hand side, different CCG areas. So this was across Cheshire, Merseyside and Lancashire and South Cumbria. So all the way from Crewe in the south to up to Morecambe Bay. And if you can look at the green colours, they're full provision. So obviously health visiting is very, very strong. You know, there's a really good tradition of embedded, you know, and also of specialist mental health provision, health visit provision. There's lots of red, which is around 0 to 5s and CAMs. Again, some patches were in development. So, you know, each area, and also there was lots of area where there was some provision. Okay, so that was in information that we collected from there. So part of it was when, if we looked at that information, we thought, let's try and hold a summit where we pull together key stakeholders from all the different sort of groups and have a large invitation. So as I'm speaking now, there's 128 participants, so people have joined us. So if you've just joined, welcome, and I'm just setting the scene now. Okay. Okay, so next slide, please. So when we've sat down and thought, what is the vision? What would we like to see? And this is a start, an attempt at setting out a potential vision and what people want to do. So we thought about using ideas of best practice. Okay. Yeah, we talk about evidence-based, and evidence-based relies on research evidence and shared decision making, and also professional and staff judgment. Okay, but also the idea of shared decision making about engaging mums, dads, carers. Okay, we thought that the idea of services that work for families, which are co-produced with them, which are effective, and also keeping our populations healthy. So rather than trying to take a public health view as well. And one thing was conscious of when we thought about this vision about generational cycles, the idea of disadvantage passes down through families, and how can we break that? And I know there's so much interest in ACEs across the participants, and so with the obvious implications for the generational cycles. We think as a vision, as a start, is about integrated commissioning across maternity services, children's, young people, mental health services, health visiting, educational, local authority, third sector. There may be groups missed off there. So again, that might be something people want to comment on. Is there participants today who've got a key a role in that, and that doesn't quite capture? So I know there's participants today from all of those sectors, and each have their sort of strengths and weaknesses about how they work. So part of the thing that we thought about was really, really important was this sense of a community of service providers working together. Okay. So next slide. So how are we going to get there? So when we were presenting, someone in our group had a quote, and hopefully someone can tell us where it's from, but it makes sense and it really captures something. So this idea of collaboration is harder than competition. So a key issue that when we were thinking, the group who developed this workshop today and this summit, sorry, we were thinking that when we look around the country and look around the region, there's no area has got this right. There's no area we can point at and say that is a model because we think it is so hard. Okay, we think this is hard work, and that part of moving on is to sort of accept that this is a tricky thing to get right, and how can we work with that? Because we think it's very, very complex. If we start to just look at individual families or individual services, the pathways are so complex. So part of today and for you for learning for yourselves is this idea of joining the dots about, just basic things like co-location. Some services have this concept of hubs, physical hubs, or is it virtual of physical hubs? The idea of co-locating workforces, staff, pathways. Okay, the idea of being able to describe what's meant to happen, and also multi-agency, multidisciplinary teams, so that the contribution of different agencies and different professions so contribute each other. So this whole idea of collaboration, how do we do that? And obviously collaborating with families, mums, dads, carers, really listening hard and engaging, what environments and what services to under 5 children want and infants. Okay. Part of how we're going to get there, we're developing a group called the Best Start for Life, because we think that sums up what this is about, and that's expanding the clinic network group from mental health, which has been perinatal mental health and adult mental health, up from conception to age 5, in particular thinking about where would the gaps be. So are they on 2-year-olds to 5-year-olds? What's apparent there? Okay, and also building on the work of the PIR partnership, and which is looking at perinatal infant relationship, parent-infant relationship work, and thinking about that. Okay, so what I've done now is just set the scene, which is a key idea of how we'd like people to sort of think about today. So what we're going to do now is for people who have had a go at Mentimeter. So let's have a go at this. So what do we need more of? Okay, and then on the bottom there's a list. So I'm just getting my eyesight here. So there's a list of groups. So if people can go on there now, okay, and just have a think about in their area, which would be one. What do we need more of? Okay, so again, if you look on the screen, there's people. I'm pretty sure you can vote only once, so people may want to be really keen and struggle, but just be one thing. So this is just good to get people thinking about that. Okay, so specialist relationship-based interventions. So video interaction guidance is getting a lot. Okay, adult mental health services, people are feeling that isn't a key for them, but that's maybe to do with our priorities of the participants. Okay, there's 2 people that put something else. So those people who've put that would be really interesting to note if you could put that in the chat. Okay, health visit interventions. So again, if I'm thinking there's 134 people, I'm just adding that up quickly. So have a think about which one. It might be something else, which would be fine. Okay, so this is the first for today. This is the first use of Mentimeter, so it would be good to have just a practice. Okay, and someone in the chat saying about there's something else is Sure Start, bringing back Sure Start. Okay, someone else said about peer support. Okay, again, I'm sure there's interesting examples of peer support, and it's something which services are beginning to explore, so that might be something people can talk about in the breakout rooms. So again, there's people are adding, yeah. So again, someone's confirmed yes to Sure Start, and it'd be interesting to think about what the features of Sure Start people felt was strong. What would be the key component of that? Yeah. Integrated early attachment service. Someone else has put, which is great, yeah. Okay, so people have commented about the hubs, the family-based hubs, and how similar the Sure Start, and also someone's commented about neurodevelopmental, and I think that's important in terms of services being inclusive to children with additional needs and parents with additional needs, which is a challenge. Okay. So again, there's a comment about how are the hubs model, are they replicating the Sure Start model? And again, that's something Amy may want to talk about. So we'll have a few more minutes to people for people to comment on that. Okay, so in terms of the family hubs and Sure Start, Ruth's commented how it's maybe slightly different model, yeah. And the family hub approach, that again, that would be something to talk about in the group, so we can comment on. That'd be great to hear about how that's across the patch. Again, if we think about the scoping exercise we had, what we'd picked up was that the variation, which is something that we want to think about. Some variation is appropriate because again, I'm conscious of it's a huge patch. It's very diverse. We have cities, we have rural areas. Yeah. People are commenting about the settings which families find themselves in about poverty and disadvantage. So someone's commented to think family hubs are more multi-agencies than Sure Start. So again, people who can remember Sure Start, that might fit. Yeah. So again, Karen's picking up about different hubs and have different focuses. Okay, if you, in terms of, is there any areas that are planning family hubs so that on the horizon? Again, we're having a discussion here about some from Lisa's about the family hubs being a difference. Okay, so this is great. So again, use the chat because we're capturing this and looking at, we can look for themes. Okay, Elizabeth from East Lancs. Okay, about this is everyone's business, and maybe that's harder to. So we've got lots of. So just looking at here, the Mentimeter, yeah, is the highest is 28. Okay, which is around specialist relationship-based interventions, so particular skills. Okay, and again, people are, you know, really raising the whole point of government investment, and that might be something we can look about. To what extent there's variation, are some areas have greater investment in this area or not?
Neil, you've got 2 minutes left.
Okay. So thanks for that. That's in terms of this is a useful thing to do in terms of capturing this. Okay. So the next one is how can we support the workforce? Okay. So let's have a think about using a Mentimeter. Which one would, what people have come across that there? So the first one is training, clinical supervision, case consultation, join the pathways and co-location. Okay, again, people in the chat are talking about the impact of poverty, which we should, you know, always have in the forefront of our minds, and inequality. So if something the pandemic's told us, it's about how different families are affected differently, and that it's moderated by their conditions of poverty. Okay, so how do we support the workforce? Joined up working, so that mirrors about the collaboration. Okay, so between second and third, it's very close. Okay. So again, there's in the chat, people talking about family hubs. Lisa's comment about family support. Okay, so something else is how can we support the workforce? People have put something else. If you want to put in the chat what the something else is. Joined up working and pathways. So that goes back to sort of collaboration and linking up. Which again, that's really, really great to hear about. People feel out of this. So there's 138 people on this meeting today. So that's first. Okay. So thanks for that. So what I'm going to do now is I'm going to introduce you to Karen, who's Dr. Karen Bateson, who's going to introduce herself and take us through a key issue which we're going to listen to carefully. Okay, over to you, Karen.
Thanks, Neil. I'm just going to share my screen.
Yeah, sorry, Philip Hayes, could you turn your camera off, please? Thank you. Sorry, Karen.
Neil, can I just check you can see my screen okay?
I can see your screen, yeah, thank you.
Perfect. Okay. Welcome, everybody. Thank you so much for making time to attend this morning's event. We were hearing in the breakout just before we started how much pressure everybody's under. And I think the fact that people have made the time and commitment to come and think about this issue this morning is a real testament, actually, to our commitment to families. I'm Dr. Karen Bateson. I'm Head of Clinical Strategy and Development at the Parent Infant Foundation, which is a charity that supports teams around the UK to develop and strengthen their parent-infant relationship work. I've worked in this field for over 25 years, and the kind of guiding light of my career has been what can we do to support today's infants to become tomorrow's healthy and happy and productive citizens. And so I'm going to speak to you till about 1:45 about the kind of the science and evidence and practice of that. We are definitely seeing a lot of pressure in the system. We're seeing demand for specialist services, mental health services and safeguarding increase, exacerbated by the pandemic, obviously. And you might be wondering, what has the mental health of very young children got to do with all of that? And the answer to that is that the quality of the parent-infant relationship, so how we interact and support and nurture our very young children, starting from conception, is one of the key mechanisms by which our lifelong outcomes are enhanced or diminished. So the parent-infant relationship sits alongside those other factors that we know influence later life outcomes, things like poverty and like adverse childhood experiences. This was a report published in 2019 by Public Health Wales, looking at what helps children be resilient to later life mental health problems. And we know what the risk factors are. We know that poverty, child maltreatment and adverse childhood experiences, including parental mental ill health, sit alongside a kind of significant parent-infant relationship difficulty and other genetic and neurodevelopmental issues in terms of putting children at risk of later mental health issues. And when you look at the resilience factors, as outlined in this report, we know that good quality relationships, social connectedness, strong social and emotional development, and good general health and well-being are all really important factors in how resilient a child will be. And for very young children, that all of those are predicated on the quality of the relationship between that child and its carers. There are also two other factors identified in this report. One is a growth mindset, and one is involvement in community and sports activities beyond the family. Obviously not quite so relevant to very young children, but really relevant once children get to school. So these are some of the outcomes which research has demonstrated can be influenced by the quality of parent-infant relationships before the age of 3. So you can see that they are things that trouble us. Physical health issues, including drug use, criminality, antisocial behaviour, speech and language development. Now, that's not to say that all of these things are caused by parent-infant relationship difficulties. Many children with difficulties in these domains have perfectly good enough parent-infant relationships. But where there are difficulties in that really important relationship, the important message is the impact of that is not restricted to childhood. It is likely to show up later in life in a person's mental health and other domains of personal development, potentially throughout the lifespan. And if you want to know more about that evidence base, there is a series of evidence briefs on the First 1001 Days website. This one is evidence brief 3. And there's also the Harvard Center for the Developing Child, which has really good and accessible reviews of the summary, of the evidence rather. The other thing to say is that the risk factors interact. So where children experience adversity in early life, it makes them more likely to experience other forms of adversity, both as children. So if you're born into poverty, if you experience ACEs, or if you experience a significant parent-infant relationship difficulty, you're then more likely to go on to experience those other things later on in life as a child, but also more at risk of passing those patterns of parenting and patterns of adversity onto your own children when you become a parent. The economic case for investment in early relationships is strong. This is an evidence brief from the same series. We know that there are no silver bullets. So what I mean by that is there's no one way to support every family with every difficulty. This is very much about systems working together, being joined up, and providing a range of different kinds of supports for families at different levels. But we know that when we strengthen early relationships, that is a sound economic investment, and that the earlier you invest your money, the greatest the return on investment. I'm not going to labour that point, but I do want to show you just one study that came out last year. This was a large study conducted in the UK by King's College London, published last year. And what they found is that teenagers whose parents were less sensitive when they were young, so by the time the child had got to 4 to 6 years of age, those children cost on average £22,000 compared to only 1,600 incurred by those children who were more sensitively parented. And sensitivity is a key aspect of that important parent-child relationship in early years. Now, the reason I chose this particular study to show you is because it demonstrates that within a decade, we can make a savings of a factor of 13. So that's within a decade. So these aren't necessarily, we don't have to wait generations to see the impact of work in the early years. We're seeing the impact financially and through social capital within a decade. I just want to make a note about language. You've heard me use the term early childhood mental health, parent-infant relationship. So when I use those terms, I'm referring to the emotional health, well-being and development of very young children. And that is predicated on, so it's based on the environment and experiences that babies have, especially their relationships with adults. That's different from perinatal mental health. So when I use the term perinatal mental health, that references the focus on the mental health of adults during pregnancy and the first year. And often perinatal mental health is used to refer to maternal mental health, although, as you all know, the long-term plan for the NHS is that perinatal mental health will take into its scope the mental health needs of all the family. But there is a term that I just want to draw your attention to, perinatal mindset. The idea that the focus is on the impact of mental health on pregnancy, childbirth, the relationship between the parent and the infant, and on the couple and family relationships. So that's a term which is takes a much more holistic view of what it is that's important in the family during the perinatal period for all its members, including the baby. And the reason I talk about language at this point is because I sometimes hear, particularly have to say politicians, use perinatal mental health, parent-infant mental health interchangeably, and that's not particularly helpful, because I think what we are saying is we do need perinatal mental health. We also need a focus on the child, and the perinatal mindset is about all of that. For people who are interested in the overlap between perinatal and parent-infant or early childhood mental health, I'll just give you some anecdotal data from Northern Ireland. So the Parent Infant Foundation works with teams all around the UK. And one of the teams we work with in Northern Ireland, at any one time, between 50 and 80% of their referrals for early childhood mental health and parent-infant relationship work, 50 to 80% of those referrals don't meet the criteria for a referral into their perinatal mental health service. And that includes children who are presenting primarily with a presentation around child abuse and neglect, but without an obvious moderate to severe maternal mental health problem. And this whole idea of early childhood mental health and relationships can really challenge systems, because we're very much in the mindset, we've very much set up services as either children or adults. And when we're talking about early childhood mental health, we're actually focusing on relationships. If anybody wants to know more about infant mental health, there is a short video on YouTube. I'm not planning to show that today. But I just want to reassure people that when we talk about early childhood mental health, we're not suggesting that this is about applying concepts that we've learned from adult mental health and superimposing those on young children. So when we think about mental health, we often think about diagnoses or medication or talking therapies, that kind of thing. And those are not concepts we're superimposing onto children under 5 when we talk about young children's emotional mental health. We are talking about young children needing specialised understanding of their unique vulnerability during a very important phase of development. How you all notice and describe difficulties or the emotional development of young children is very likely to depend on which glasses you look through. So if you come to this topic with a lens of mental health, like me, you're likely to be familiar with mental health language. But if you come from a speech and language background or a family support background, you're probably used to using different kinds of language. But essentially, all of this work is contributing to the emotional well-being of very young children in some way or another. The crucial issue is that when things go wrong in this, sorry, I've lost my mouse. When things go wrong here, lots of things can help, but we really do need to take it very seriously, because it has a disproportionate impact on multiple aspects of that child's life later on. So you may be able to find yourself on this flower diagram. I apologise, it was my oversight not to include housing, because as somebody said earlier on, poverty and related topics such as the environment in which children grow up and their housing situation obviously has a massive impact on how children experience family life. We know that all of these people are contributing in some way to the emotional well-being of young children through the parent-infant relationship. But the foundation, the Parent-Infant Foundation, also advocates for specialist interventions when families need more help than universal or targeted services can offer. So what's that based on? Why are we saying that we need specialised parent-infant relationship team? Well, part of the answer is that babies are very different from older children. Children under 5 and particularly children under 2 are a different entity to older verbal children. Obviously, they're developing extremely quickly. Their nervous systems are extremely fragile and vulnerable to environmental influence, including the relational environment. They can't tell us, they can't communicate what they need, so we have to be very good at reading that. And they're completely dependent on their adult carers. So what is it that distinguishes early years mental health work from perhaps CAMS work in older children, or work with younger children that's maybe in universal or targeted services? Certainly we know that everybody except parent-infant psychotherapists, so psychologists, child psychotherapists, health visitors, nursery nurses, social workers, voluntary sector workers, everybody needs post-qualification training to be able to develop the specialist skills and knowledge required to work at a specialist level with early years mental health. And that post-qualification training is around being very highly knowledgeable about typical and atypical child development, having a very detailed understanding about how pre-verbal children communicate. This is critical, understanding the unconscious process. So in other words, understanding how, without meaning to, so completely inadvertently, parents bring their own experiences of being parented, their past unresolved traumas, and maybe even their current stresses, how all of that gets brought into the relationship with their young child and transmitted and communicated to the baby. And that's one of the key mechanisms by which difficulties get passed from one generation to another. And this ability to work very systemically, so the idea that you're working with a parent and a baby, you're working with yourself in the room with the parent and the baby, potentially multiple parents. So there's a lot of dynamics going on in the room, but also the idea of a parallel process, how I communicate and support parents then influences how the parents communicate with and support their baby. And I just want to kind of acknowledge how hard this can be to think about. So it's hard to think about babies in distress, being helpless to communicate that or help themselves. So working with very young children does require a lot of curiosity and compassion and self-reflection. It's highly skilled work and often complex, so skilled supervision is essential. So let's talk about what our aspirations for specialised parent-infant relationship teams might look like. What you can see on the right here is a kind of a description of what good looks like from our developmental and implementation toolkit. And in summary, that is that we have teams in each area that are multidisciplinary. They accept referrals for children under 2, from conception to under 2. That there's a focus on parent, infant and family relationships, that they tailor their assessment and their intervention to the family based on a skilled formulation of what the family needs. That teams have consultant, psychotherapy or psychology input, ideally both, and that the team acts as an expert and champion for early childhood mental health across the system through a range of supportive activities. And as I've said, the Foundation supports all areas of the UK that are looking to develop their parent-infant offer. And these are the common questions that we often get asked. Where does it sit? Who leads and funds and coordinates? How do we join together and where do we start? And if there's one key message I want to leave you with today, it's that these are very common challenges. And as Neil said earlier, everywhere's trying, everywhere's making progress, but nobody's got this cracked yet. So I do want you to kind of give yourselves a big pat on the back that you're thinking about this and trying to work it all out. I will tell you about some examples of good practice in a minute, but we don't prescribe how things should be in an early years mental health system. It's much more important that you do what you're doing, which is coming together and talking about what your local landscape looks like and how you can craft an early years mental health system that works for your local area. One of the things that we know does help is having some kind of multi-agency strategic forum to think about that, with some kind of multi-agency group to oversee the translation of those strategic plans into some form of action. So what does good look like? It looks different in every area, and the way that services join up looks different in every area. But what we know is that partnership working is critical, particularly to include the voluntary sector. Many parents who are, many families with very young babies who are starting to have difficulties and need to build trust, and may well have had experiences themselves of finding life difficult with helpful professionals. And so somewhere that families can build trust is really important. We know that multiple opportunities to work together, so actually doing joint work, doing joint visits is helpful. Consulting parents about what your system should look like, how accessible it should be. Parents will always tell you that they want local, accessible support services that include dads and partners. To co-create care pathways. So that's been mentioned several times already this morning, but to come together and thrash out what your care pathway looks like and what, as Neil said, what should be happening. Multi-agency strategic planning that I've already talked about. And for those of you that know the Thrive framework, Thrive framework is a model of systems transformation, and it's built on the idea that we try to match families first time to the level of support they need. So we've been doing some work with Wales on designing an early years mental health system for them. The next slide I'm going to show you describes what that system will look like, and I'll just talk you through it. So this is an aspiration of the future. This isn't how things are at the moment. So in our vision of the future, families can build trust and access help through both formal and informal routes of entry. And when they access help, there's a good quality assessment that matches them straight away to a universal, targeted or specialist level of intervention. So we try and get away from the idea that all families have to be escalated through the levels, because we know some families fall off those escalators. And all staff across the system have access to advice about parent-infant relationships. So what does it look like? What do I do when I see a difficulty? In our vision of the future, everybody who assesses families, so GPs, anybody who is the first contact for a family, knows what to look for, how to get advice, and which level would match a family's needs. And then once families get referred into help and support, that specialised parent-infant work or early years mental health work is highly integrated with targeted and statutory services. This is Welsh language, by the way, that it might not necessarily match exactly how we use these terms in England. We know that universal services have to retain a role with all families, no matter how complex or specialist their needs. And this should all be bound by a strategic workforce development plan. We were hearing this morning how lacking the workforce development plans are across the UK. So let me tell you about some examples of where this works. In North East London, Foundation Trust, they have a fully integrated perinatal and parent-infant mental health service. So the two services are fully integrated, and referrals can come in regarding the parent's mental health or the child's mental health, and they'll be seen and offered a holistic care package. In Keighley, there is the SEED team. It's a ring-fenced part of CAMS for children who are aged 0 to 7, and they focus very much on the social and emotional and attachment development for those children. In Essex, the join up is that the psychology lead across the perinatal mental health teams and the parent-infant mental health teams is the same person. So that massively helps the integration between the two. And in Cornwall, they are setting up a brand new parent-infant mental health service at the moment. It will sit separate from CAMS and adult mental health, but the lead for the parent-infant work will actually have a strategic lead role across perinatal mental health, health visiting and midwifery. So examples of very different setups, but kind of innovation around integration. Okay, I'm going to quickly finish off because I'm aware I've only got 1 minute left. The work we did in Wales, and we're just finishing, included a parents' consultation We gathered the views of 487 parents, which I think is the largest survey in this field. And what we found was that when we asked parents, how highly do you rate these factors in your child's development? You can see that being in a home where there's violence and where parents use drugs were rated highly, and rightly so. But surprisingly to me, the relationship between the parent and their baby featured more highly than parents drinking heavily, parents arguing, and parental mental health. So what parents are telling us is that they know this is a really important phase of development, and they know that relationships really matter. They aren't being asked enough, how's it going with your relationship? And when they are asked, they value it massively. By not asking, we kind of create a taboo that perhaps you shouldn't talk about it, just in case somebody will judge you or take your children off you. So if I can leave you with that message that parents want to be asked more about their relationship with their young children, and they're ready to access help and support. I'll finish there so that we finish on time.
Okay, thank you. Thanks, Karen. We've just got, there's a question about, can we access the data on the PIF website?
The report will be going up on the website tomorrow, but I'm very happy to share it with people if they want to email me as well.
Okay, so Karen, there's going to be some questions popping up in chat, whether you want to take them through the morning, or there's a little bit of a slot now. I'm
happy to take questions through the morning. I know you've got another speaker to move on to, so if people want to pop questions in the chat box, I'm very happy to answer them.
Okay, thanks very much, Karen. That was great. That was really thought-provoking, especially, towards at the end, very striking about, parents' views, what I think are really important. Okay, thanks very much, Karen. So the next speaker is Beth, who's going to take us through an outline of the national agenda. Over to you, Beth.
Thank you, Neil. Thanks to Karen for a great presentation. I'm just going to now quickly talk about how this work in the North West Coast fits in with the national directives and NHS England and NHS Improvement. So Rosie Allowett from the National Team for Perinatal Mental Health put these slides together, which I'm just going to present to you today in her absence, as she wasn't able to attend. So Rosie Allowett works for the National Perinatal Mental Health Team, and this work for early years mental health will be sitting under that Perinatal Mental Health Team. So we know that the long-term plan has a 10-year ambition to ensure that 100% of children and young people have access to specialist care when they need it. And we know that the long-term plan implementation plan sets out funding available up to 23-24 to support this. So we recognise that this issue is not just about mental health services for children, and that we really need to take a holistic approach around all the services that support infants and young children. So we're looking at development and investment in health visiting, universal services, children's services, parenting support, and many more other factors that will contribute to this ambition. The development and investment is going to look different in different areas, as this will depend on local population needs, and commissioners and service providers are expected to consider those local variations. So up until now, the development of CYP mental health has focused mainly on school children and the 18 to 25 year group. However, now we're looking nationally at further service development for 0 to 5 age group. As Karen covers so well in her presentation, we know that this investment makes sense due to the importance of the child development in these early years. And we've got strong evidence coming out in many reports and studies. We're starting to see more examples of good practice, but as we've shown, this is very patchy and variable across the country, and so we'll be looking to build on these examples of good practice. So the work that's going on in the national team at NHS England and Improvement is the first stage, which I believe is underway at the moment, is scoping work to understand the current provision across the country and looking to collect data nationally in early 2022. And as part of that, there will be a programme of sharing examples and best practice of services for 0 to 5s. There's news of HEE developing an e-learning package for parent infant practitioners, hoping to see that in spring 2022. And then just a nod there to the RC site guidance of CR 232, which describes the need for multidisciplinary parent-infant mental health strategies and how that ties in with the integrated approach to perinatal and infant mental health care pathways. And the Start for Life funding, again, is on this sort of integrated agenda around perinatal mental health and parent-infant relationships. So those are the slides from the National Service. I think because we'll save some time with me racing through those slides, it's probably a good opportunity now to open up some questions, especially if anyone's got any questions for Karen.
Beth, I've just been responding to some of the comments and questions in the chat box, and I think what's really clear, and I couldn't agree more with, is the importance of investing in the workforce. So we know that COVID's had that extra, has exacerbated all the pressure that services were already under. And people rightly saying, you know, we really want to know more and do more about this, but we are on our knees, so we need investment in workforce. And I would add to that a personal note, a national workforce development plan, because at the moment, as far as I'm aware, there isn't a national workforce development plan in this sector in any of the 4 home nations.
Okay, so there's lots of comments in the chat, Karen, confirming and finding, you know, your presentation really thought-provoking and sort of touching home, really. Lisa comments about how desperate families are to talk about their relationship, their, you know, mum's relationships with their babies. Could you say a little bit more about how professionals can some work with that, and is that a universal thing, or is that a specialist thing?
So we've done research with both Essex and 3 areas in South Wales now, and that is a universal message from parents that they know that this is important, but they are worried about asking for help because they're worried about being judged or having their children removed. And so they don't mention it, and they're not being asked by a GP, health visitor, midwife, or anybody else. But when they are asked, they are massively relieved and really keen to talk about this because they know how helpful it is. What we found with the large Wales sample was that around 15% of parents, often the parents who are already facing some challenges and adversity, found that just being given information, so, you know, all that good stuff that we kind of write in leaflets and we tell them about apps and all of that stuff, when we do that, for this particular 15% of families, that makes them feel worse, not better. Because it compounds a sense that they're not achieving the ideal already. So there is an important message for practice, which is talking to families about what's normal rather than what's perfect or ideal. And what's normal is, you know, not all relationships, not all not parenting's not easy. Lots of people are struggling despite what you might be seeing on social media, and actually it's entirely normal to have struggles from time to time, and there's a real strength in talking about that and asking for support when you need it. And equally, we just need to make this part of an everyday conversation. How's it going with your baby? How's your relationship developing? Is your relationship developing in the way that you thought it would? So yeah.
Thank you. There's also a question Karen, because we've got some time for some more from Michael, who's asked, are there examples of services that are integrated across health and social care, retraining or co-location? Is there something that stands out that you feel that people could look at maybe?
It's something that I'd really welcome. I'm assuming that's Michael, who works in
Michael
parent and baby.
Galbraith, yeah.
Yeah, hi Michael, Parent and Baby Relationship Service in Liverpool, which is I'm going to big you up, Michael. It's a really fantastic example of very close integration between mental health and social care. And there are other teams and services across the UK where there's a better level of integration, and that makes really good sense because working with very young children delivers outcomes that map onto safeguarding outcomes. You reduce safeguarding risk, you improve speech and language outcomes, you improve readiness for school, you reduce the risk of mental health difficulties. So although I'm talking about it in mental health language, actually it would be really good to see a much closer integration between all the different parts of the system that support very young children, because everybody stands to benefit. So there are a few examples around the country to answer Michael's question directly, but it's not as common as it should be.
Okay, thank you, Karen. I'm just wondering, I'll be cheeky as chair and ask and quickly pinch a question. Is there anything from other countries that we could learn from in terms of teams or service models?
That's a massive question.
All right, it's too big.
No, I will answer it quickly. Obviously, Scandinavia get this stuff right. And that's a whole system. That's a whole political system that's focused on the well-being of children. They've invested, as a whole country, in happy childhoods and healthy childhoods. We went to Finland as a family in 2017, and the guy who took us ice fishing had a 7-year-old who was just about to start school. And he lived out in the sticks, and I said, how's he going to get to school? And he said, the government built us a bus stop.
Right.
I thought, there you go. That's how Scandinavia do it.
Yeah.
And we did have a webinar recently from a service in Australia. They've been set up 20 years, fully integrated perinatal and early childhood mental health service. And the message clearly from them is, you will not have the workforce at the moment you need it, but just get started with what you've got. Everybody across the workforce has something to offer in this space. So crack on and do what you can.
Okay, thanks for that. So in terms of if we visit your website, that might be a link to some of the sort of overseas work if people want to get some ideas and thinking, yeah.
We don't have any information about overseas stuff on the website,
Okay.
but we do have a very comprehensive development and implementation toolkit. So that's got 9 chapters, interventions, outcome measures, commissioning. There's, whatever you need, you should be able to find it in the toolkit.
Yeah. Can someone put that in the chat then as the web, please?
Yeah,
Is that okay?
Yeah, I will do.
Okay, so I'm just looking in the chat of Liz Johnson. It's put an interesting graph where I can't quite see the details, so people might want to. Okay. I like this graph's reduction in prevention spend mapped against the increase in children's social care. So I'm guessing, Liz, without looking at the detail, you're looking at the role of investment and impact. Okay, because one of the things I know people on the call today are quite interested in, Karen, as well, is about young infants who go into care in very, very difficult circumstances. So that might be something people pick up on about the role of social care and preventing that, etc. Okay, so thanks very much for Karen for that. If you are you staying with us for the rest of the morning?
Sorry, I switched myself off. I will be around for most of the morning, and I'm facilitating a breakout room in a.
Okay, great. So again, if Karen, you can pick up questions as well. Okay, so
Sure.
someone's after some references for Scandinavia, but I'm not sure if they want to go fishing in Finland or they want to develop services. Okay, thanks. Well, we're nicely on time now, so we're going to have a 10-minute break. So if everyone switches off their cameras and mics and comes back at 11:10 and make sure everyone has a wander around and a break from the screen. Okay, so see you back here in 10 minutes. Thank you. Hi everybody, welcome back. We're on time, which is great, and I can see people are slowly coming back. So what I'm going to do next is introduce you to Claire, Helen and Michael, who are going to talk about their work in Liverpool. Can I just remind people to switch off their mics and their video, and over to you, Helen and Michael and Claire, and I'll let you introduce yourselves. Thank you.
Thank you very much.
Sorry, Francis and Claire, could you? Thanks. Sorry, Helen.
You're okay. Can you just let me know if you what you can see?
Helen, I can see that.
Yeah, is that showing just the slides there?
Yeah, that's good. Francis and Claire, could you switch your videos off, please? Thank you. Sorry, Helen.
Claire's part of the presentation, by the way, Neil.
Oh,
so...
sorry, I got mixed up. Sorry, Claire, I got my Claire's mixed up there. Sorry.
That's okay, don't worry.
Okay. So can you see and hear me okay, and you can see the slides?
Yeah.
Right.
Yeah,
okay, thank you. So yeah, I was really quite humbled to be asked to speak at this and asked to share how services in Liverpool at the moment are working to support parent-child relationships and mental health in the early years, and straight away thought we've got to try and do this collaboratively. So really pleased this is a joint effort between myself, so I'm Helen Honour, I'm a clinical psychologist in Liverpool's NHS Fresh Cams service, and a part of my role is developing our early years offer, as well as Claire Goldson. Do you want to say hello, Claire?
Hi everyone, I'm Claire Goulson. I'm currently acting up Family Nurse Supervisor for Liverpool Family Nurse Partnership.
Thank you. And Michael.
Hello everyone, I'm Michael Galbraith, clinical psychologist and family therapist. I lead the parent-baby relationship service, which is based within PSS, which is the third sector organisation in Liverpool.
Great. So we're here to share our offer, and I suppose kind of from a CAMS perspective, by no means kind of say this is exactly how we'd like it to be, but we'd like to kind of give a flavour of our offer and the reality of the work through a case example of some joint thinking and joint linking together, share some of our reflections on the strengths and challenges of that, as well as some of our hopes. And what we will ask you to do is for you to actively reflect on what you hear, so that you can take something away that informs either your role, your practice, your service, your area of work. So just briefly setting the scene about Liverpool's context, I'm not going to go through it, but just highlighting how in Liverpool, perhaps similarly to other areas of the northwest coast as well, Liverpool's babies, young children, they face a really difficult start in life. So from pre-birth and early years, many outcomes are worse than the national average, which is shown in red, albeit some notably are better, shown in green, couple similar in yellow there. And kind of as seems to be a theme from this morning that I'm picking up is, you know, Liverpool's not short of people passionate to overcome these challenges. So kind of as Neil's spoken about, there's national drivers, but at a local level, some of the drivers that support our early years work, some of the strategies include Liverpool City Plan, One Liverpool strategy, and the Starting Well strand of this, which all highlight that we need a radical upgrade in prevention and early intervention across the life course, but also specifically kind of optimising those first 1001 days of a child's life. And we also want to acknowledge that our early years work is also very much influenced by kind of a history in Liverpool of recognising the importance of early years and early intervention, and previous service models which have left their mark, we think. Okay, so I think kind of as Karen might have mentioned previously, or kind of certainly is highlighted by the Parent Infant Foundation, when CAMHS services, when kind of looking at kind of whether CAMHS services are working with the youngest children, it was found that many CCGs are explicitly not commissioning mental health services for children under 5, and even those who are, a significant proportion of them don't have children under 2. So we are really pleased that our CAMHS service is commissioned to provide this service, and we do accept those referrals, and we do have babies and young children between the ages of 0 and 5 accessing the service. The numbers are small. We know the need is much higher, and we'd like to be reaching more families, and also acknowledge that usually we don't take referrals before birth, so we're kind of missing that conception to birth point. So just briefly going to share kind of what the CAMHS early years pathway is. So our whole service is informed by the Thrive model for the whole age range from 0 to 18, and as part of that we've got a specific early years pathway focusing on promoting training, consultation, and where indicated early referral and assessment, with the aim of kind of identifying issues as early on as possible. So there are different kind of aspects to the model. So kind of thriving represents babies and young children who are thriving and whose current need is support, and so that's met through kind of things around prevention and promotion. So what that might look like is looking for opportunities to collaborate where we can around developing training, or for example contributing to Liverpool's 24 Magic Months public health intervention. Then we've got the coping quadrant, which relates to kind of those babies and young children whose needs are around getting advice, and a key part is building capacity and skills in the early years workforce. So our aim is for any practitioner working with a 0 to 5-year-old in Liverpool to be able to access consultations on offer by a CAMHS linked clinician. That's the aim. So every children's centre has an allocated clinician, and any practitioner can access that clinician for that particular family's children's centre. And we kind of think about language a little bit recently, you know, kind of consultation, what does that mean? But it's an opportunity to think jointly really about a child and family, build up a psychological understanding of what's going on. Also offer consultations to the family nurse partnership, and we might decide that needs a bit more unpicking or assessment, and that can lead to the choice appointment, which is an initial kind of appointment, might be kind of leaning to some advice or guidance or signposting, or it could lead to deciding on getting more help from CAMHS. So kind of as kind of indicated, that the degree of that help might either be kind of getting help, which relates to a number of different goals focus, more evidence informed interventions, or getting more help relates to those families who might need more extensive intervention. Okay, I shall pass you over to Michael now to share about PSS.
Okay, thanks, Helen. So yes, I just wanted to kind of put down some ideas about differences between third sector organisations and NHS ones. In Liverpool, the word CAMHS is used to include service providers across the different kind of types of provision. So being based within PSS, I think there are some pros and cons of that. We're a smaller organisation, and we're a very, very small team in terms of the parent-baby relationship service. I mean, you could think about that in terms of the number of people you have to go through between frontline staff and the chief executive. In PSS, it's probably about 3. I guess in larger organisations, it's a few more than that. And I think that means that we can be flexible, responsive, hopefully. It also means that, well, it's not necessarily a consequence of this, but we tend to get short-term funding, which means that services can be less secure. Going back to a point that Karen made about families who have experienced interventions from statutory services previously, not being a statutory service, not being a service that can section somebody or remove children, means there's a potential for us to be less stigmatized. I think there's also a possibility that we're seen as kind of less serious, that we, I don't know, work with the worried well or something. We can be person family centered and try and be kind of creative around that in terms of where we meet people and ways of working with them. Again, I think there's a question, I don't know how valid it is or not, around governance and standardization. And I think that in the best scenario, the third sector can complement the work of first and second sectors. But the danger is that we're seen as kind of the add-on at the end, the extra, the side dish, rather than part of the main course. Okay, back to you, Helen.
Okay. Claire, we're lucky to have Claire with us too today. I'll let you share about FMP.
Yeah, certainly. So really great to be speaking here today. I'll give you a little update about what Family Nurse Partnership do. So FMP, we're an evidence-based targeted early prevention programme. We provide intensive support to young parents aged 19 and under, and we support our clients through pregnancy up until the child's 2 years of age. And we use a strength-based approach and a focus on behaviour change. Liverpool FMP have been going through a little bit of a transitional phase at the moment, and it's quite an exciting time for FMP. We're going to be relaunching our service. We've gone through a recruitment process, and we've got new staff, and we've got a new vision, and we're hoping to build a more integrated way of working together with the wider 0 to 19 services and local stakeholders. And we're hoping to share the ethos and the principles of FMP in the wider workforce to influence service development and to hopefully develop a more robust local system in supporting our service users, and hopefully for FMP to be able to have a wider positive impact as well. So really exciting times for FMP in Liverpool at the moment.
And we just really wanted, thanks so much, Claire. So we're very aware that we are 3 of many services in Liverpool, and kind of really want to acknowledge that there is a whole network of services aimed at supporting parent-infant-child relationships. For purposes of time, I won't go over this now. The next bit is we want to share a case example with the 3 of us involved at some point. Again, we've not managed to include everybody, which possibly reflects the challenge in reality of bringing people together around a baby and family. And of course, a different case might have involved other services in the network, you know, kind of children's centres, social care, the specialist perinatal mental health team. So Claire's just going to share a background to the case briefly, and then we will ask you some questions to reflect on.
Okay, so we have Zara and we have Ibrahim. Now Zara is 18 years of age and she has her child Ibrahim, who is now 5 months old, and Ibrahim is her 5th pregnancy. Zara has had so much trauma and adverse childhood experiences, and she's been in the care system from the age of 13. She has a history of mental health concerns, but no diagnosis. She's never really engaged with services before, and she's been wanting to be assessed since she first became pregnant. Zara moved to Liverpool and enrolled onto the FMP programme, and I've worked with her since she was 25 weeks pregnant. Zara has changed her name, her geographical location by 75 miles, and her religion in such a short period of time. She has a mistrust of professionals and she doesn't really feel listened to. Ibrahim has a child protection plan. Zara has not fitted into any mental health services, although she describes herself as having a million moods in one day. And she was referred by the GP in her pregnancy, but she wasn't accepted for any assessments. She just didn't really fit into any services really, and she didn't have any current kind of mental health at that point. Zara's relationship also recently ended due to a domestic violence incident. Zara evidently loves Ibrahim. She's really proud of being his mum, and she wants to stay in Liverpool and settle here. So that's her background.
Thank you, Claire. So as we have a brief conversation about kind of us linking, thinking and working together, just to yourself, we just ask you to reflect and note 3 things. One strength about this process that might have made a positive difference for this baby. What you see as one key barrier or challenge to more effective support for this baby's emotional well-being, and in your own role, what helps you do more of that first thing you've noted, or how do you support others to do this? So Claire, you brought so yeah, just have a listen and we'll have this brief conversation. So yeah, Claire, you brought Zara and Ibrahim to our monthly psychology consultation, didn't you? And can you share a bit about what you wanted to get from that?
Yeah, I was concerned that Zara doesn't really feel listened to, as I was concerned about Zara and her identity, kind of who is Zara. She's got such a background of childhood traumas. She changed so much in her life with her identity, her religion, a relationship, a geographical location. I just was finding it hard to find who Zara was. So I wanted to explore that a little bit further. I thought I'd use our space to be able to get a sense of her feelings from a psychological perspective, and also how I could support her, what actions I could put in place to help support her relationship with Ibrahim. Really, I just wanted to look at her roles in her own life, kind of her past life, who Zara used to be, her new role as mum, and who is Zara going to be in the future. She's changed again from being in a relationship, looking to be a family unit, to now being a single mum in an area where she hasn't got much in the way of family support around her. So I just thought it was a case that really needed a good kind of exploration into how we could support her best.
I remember when you brought her, we reflected about how much our focus was on Zara. Her experiences, kind of her story, what it might be like to be her, and wondered if this reflected kind of the importance of Zara needing to feel like kind of seen and understood, and an idea which links a little bit to what we do in our Lighthouse group, this idea that if she feels seen, is she then going to be in a better position to see her baby? And for now, perhaps we were kind of needing to hold the baby in mind and think about, well, whilst kind of helping her be seen, what would also help her to hold a baby in mind. Yeah, that's some of what I remember. After our consultation, how would you say that kind of that joint thinking made a difference, either to you, to your role, to Zara and Ibrahim?
So the day after our consultation, I visited Zara. We sat down, we explored her moods, and Helen, we discussed things like direct work, what would be best suited for her. We looked at kind of Lighthouse, VIG, PSS with Michael. I'm kind of looking to see what would best fit her, kind of taking on board her personality, what she'd best engage with. And because we'd explored her psychological complexities in such depth, it gave me more of kind of a confidence in my understanding of her needs and her need to be listened to and understood. And it shifted my understanding of Zara's mental health needs. So I had this conversation with Zara and we contacted the GP together because I felt like she needed to be re-referred back into mental health services and possibly have a GP assessment in the interim, just to kind of get the GP's input really from their perspective. So we contacted the GP. The GP didn't feel that they were the best placed person to assess Zara because of her history, because of recent domestic violence incident and a breakdown in relationship. The GP thought that she was in crisis and needed more of a crisis kind of pathway. But I just felt like kind of that she wasn't in a crisis. Our consultation gave me the confidence to be able to kind of look at it from a more grey perspective rather than the GP's black and white perspective, and kind of looking at it from my professional assessment as well. She wasn't needing to go to a hospital to spend time with a crisis team. So kind of we phoned the urgent care helpline together, and they assessed Zara over the phone and they agreed she wasn't in crisis. So they re-referred her into the perinatal mental health, and she's now also working with PSS as well. So it kind of prevented Zara from going into a pathway where she would have had to have been sitting in a hospital, and I think it kind of just made sure that the pathway for her was the best one.
Thank you. So how did then, Michael, you come to be involved, and what was your linking with Claire and other people?
Yeah, so Claire referred to the parent-baby relationship service within PSS. I'm just wondering, could I skip forward a couple of slides, if that's all right, Helen?
Yeah. To that one or the next one?
The next one. We'll just skip over that one. So for me, there's something about kind of while the diagnostic labels and pathways are kind of important to some degree, I think Zara's a good example of how people don't always fit into boxes and don't always fit along the kind of neat lines of pathways. So I've tried to represent here a meeting between myself and Claire and Zara and baby Ibrahim, and thinking about the pressures on the different parts of that meeting, of the people in that meeting. And Claire spelt out already the life pressures that Zara kind of brings with her, kind of messages maybe around people hurt you, professionals come and go, the only person you can trust is yourself. But then I'm also thinking about what kind of the pressures that Claire and I and everyone, all professionals have on them around doing things quickly, services being stretched, staff vacancies, thinking about how, you know, which model is this going to fit into? What does the evidence base say I should be doing in this situation? And it seems to me that in that moment, in those meetings with families, particularly vulnerable families, thinking about those parallel processes, again, Karen Bateson mentioned about the parallel processes that go on between, you know, how we are with parents is kind of how we want them to be with babies. And I'm thinking about that kind of organizationally, and ideas about conveying a message of hope and commitment to the process, bringing some energy to the process. I think it can be hard work to do this work with families. And overall, I suppose I'd summarize it as love, and how wherever you are in the kind of structure, whether you're a commissioner, a manager, a frontline provider, how you nurture love in the work that we do with families. So sorry, that was a bit longer than you expected, maybe, Helen, but yeah.
That sounds very powerful, and I'm wondering kind of what people's reflections will be kind of around that. I was wondering about.
Sorry, Helen, if I could just bring in Zara's perspective as well, kind of what she felt about the process, because she said to me that she's never felt listened to or felt like services were there to support her. And when she became pregnant, she felt like most services were there to support her baby and still not her. So she said that she does feel more listened to now. She feels like services are beginning to recognise that her thoughts are more important, and she thinks that she could finally be getting the right support for her. She said that if people could see people as people and listen to their needs earlier, it would stop people having some reactive behaviours like she has, like she uses aggression as a reactive behaviour or just a withdrawal from services. And she thinks that if services were actually working together to support her and listen to her, she wouldn't feel the need to fall back into her previous behaviours of coping mechanisms, really. And with regards to the voice of Ibrahim, it's interesting because speaking to Zara, she was like the voice of the child. He can't speak, and it was a case of just being able to explain to Zara that it's not necessarily his voice we're looking for, it's his perspective on his world. So it was kind of like FMP kind of was able to explain that in the language that she needed. Yourself, through our consultation, was able to help her mentalise that through our psychological speaks, and then Michael being able to promote her understanding of her bond and attachment. And so now she's beginning to kind of see Ibrahim as a person and how the world appears to him. And I think that might be the key to be able to scaffold parenting, is to have parents being able to mentalise their vision, their child's vision of their world, really.
Okay, thanks very much for that. I know there's tons to talk about there, but I'm just conscious of the time. Claire, Helen and Michael, thanks very much for that sort of actually giving us a really in-depth view into a really good bit of work. Lots of people commented about how it's clear that you three have worked together really closely, and that's that's a real strength of that bit of work. Also, Claire, people have commented about FMP and the idea of continuity of worker, and how that, in terms of the trust, is a key component, which is great. So thanks very much for that. If Claire, Helen and Michael, if you just keep an eye on the chat and try and respond to that, that'll be great. So thanks very much for that. So next, I'm going to hand you over to Tracy and Melanie, who are going to introduce themselves and talk about their work up the coast in Blackpool. So thanks very much.
Thanks, Neil.
Over to you, Melanie and Tracy. Yeah.
Thank you.
Thank you. I'm just launching the presentation now. Can you see that okay?
Yeah.
Yes.
Fabulous. Thank
you.
you. So, as Neil said, I'm Melanie. I'm currently a development manager here at the Centre for Early Childhood Development in Blackpool, which, for those of you who've not heard of that before, it's the engine room of the Blackpool Better Start Partnership. And I'm going to chat a bit more about the Blackpool Better Start shortly. We've heard from some amazing speakers today. I can only echo what Helen just said about feeling sort of really grateful to be able to speak here today, and I'm definitely in awe and fangirling on some of the speakers. So I hope we can live up to that, or at least try to anyway. So we want to share some of our work here in Blackpool. So I'm just going to let Tracy introduce herself, and then we'll move on to the rest of the presentation.
Hi everyone, my name's Tracy Greenwood. I'm a specialist health visitor in perinatal and infant mental health in Blackpool, working for the NHS Trust.
Thanks, Tracy. And like Helen said, I was reflecting on that, and Neil, your comment earlier about how collaboration is harder than competition. But I think that is one of the strengths of all the 5 Better Start sites, is the fact that it's a partnership and it is collaboration. And I am truly grateful that Tracy's here and has collaborated with me on this presentation here today. So we're just going to talk to you and share some things about our community approaches in Blackpool. And we've heard from our speakers about the national context, but let's reflect now just a little bit about Blackpool and the context here. So for those of you who might not have heard of Blackpool Better Start, it was in 2015 with £45 million of investment from the National Lottery Community Fund. Blackpool became one of the only 5 areas in England that were selected to really trailblaze service transformation from conception to 3, which would then help give our town in Blackpool, the babies, a better start in life, because we really want them to be able to have that opportunity to reach their potential. So it was recognised, like we all do here today, that working earlier in a child's life and addressing issues when they first appear was really the best way to do this. So each of the Better Start local areas has developed its own distinct strategy to improving the 3 key child outcomes, and those are highlighted on this slide. So that of diet and nutrition, speech and language, social and emotional health, and underpinning all that is our drive for systems transformation. So we're now in year 7 of 10 years of Better Start, with the funding now invested in evidence-based programmes that have been researched, tested, and have really proven to make a difference to children's well-being. So our vision is for every new baby in Blackpool will enjoy that early care and nurture that they need for healthy development and to be ready for school. But we know, and we're all here today because we're really passionate about good mental health, and that we know it's part of that healthy development. So we're going to explore more about how we're supporting that in our community approaches. But before we move on to the bulk of the presentation, I'd just like to highlight this slide. So this slide, the theory of change that's illustrated there, we frame all of the work that we do here in Blackpool together using this overarching theory of change. So the idea is that if the stresses that parents faced were reduced and that parents were supported to increase their capacity and their capabilities to parent, then this will lead to improved child development outcomes. And it would crucially provide children with a firm foundation at this critical stage in their life from which to grow. So Karen spoke really eloquently before about the national context and thinking about how we speak and the language around early childhood mental health. She also spoke about nationally about what the need was, but let's think about locally in the Northwest and then in Blackpool, what we considered about the need, because we're all here today, aren't we? Because we care about babies and children's mental health, and we want to learn from each other about how we can do things better. So we're distressed by the ever increasing statistics that's showing the state of children's mental health. So nationally, this was with 1 in 6 in 2020, children being reported to have a probable mental health disorder, with many of these problems having started at a really early age. So we know from what we've shared here today that difficulties in social and emotional development can increase with adversity. And we know that compared to the national average, many families in Blackpool are experiencing higher levels of adversity, trauma, deprivation, and being born into care. So in order for us to understand the need and the existing provision in Blackpool, we undertook a scoping of early years mental health provision, and it really identified that there was a scarcity, and this was a few years ago, and we've done this again since, but originally there was a scarcity of support for mental health in under 5-year-olds. And it really echoed the findings of the Parent Infant Foundation, that these higher than average levels of adversities, when coupled with limited infant mental health services, indicated that supporting parent and infant relationships and early childhood mental health was both timely and absolutely necessary in order for us to improve the outcomes for Blackpool children and their families. So how is the Blackpool Better Start Partnership working together to help support good mental health in the under 5s? So we've adopted this community approach to mental health in pregnancy and the early years. So we here today all know that early experiences matter a lot, and that during the infant and early childhood years, there are so many opportunities where we can really promote mental health and emotional well-being, and we can really support our parents to develop this responsive, sensitive and nurturing relationships with their baby, all of which helps to prevent poor mental health. And we know if we intervene early to treat mental health problems before they can manifest into severe problems later in life. And to do this, we've been developing this continuum of support and investing early. So let's have a look at what that looks like. So this gives you a flavour on this slide of the things that we're going to move on to talk about now. So there's 4 sort of key approaches: our community connectors, which are our peer support of local parents, our Baby Steps antenatal education programme, our health visiting offer, and also we really want to prioritise our dads and partners. So we're going to chat about how we're doing that as well. So I'm just going to introduce our first community approach, which is our community connectors. And these pictures are our community connectors that are working with us on the slide here today. So I brought them with me to say hello to you all, so you can meet them in, you know, it'd be great if they could all be here in person, but this is the best we can do today. But our community connector team has both community health and dads connectors. They are all local parents who advocate for our work, our values and principles, and are trained to connect with families so that the families are then better connected and linked to other families and to all the community resources we have in Blackpool. And this then helps our families to make more positive parenting choices, both for themselves and for their children. So we see our connectors as being a real pivotal in sharing public health key messages. They advocate for families, they really support co-production and the delivery and engagement in our Blackpool Better Start programmes and interventions. Infant and early years childhood mental health is something we can all think about, and not just for professionals. Our connectors can help families to think about the areas like mental health, and they really hold our families and their babies in their minds. So our parents value the support of our connectors so much. The value of peer support was also echoed nationally in the recent findings last year from the Duchess of Cambridge, whose survey found the importance and value of peer support, particularly the element of no judgment. This was really important to parents, and in that survey there were 70% of parents reported feeling judged by others, and among these parents nearly half felt this negative impacted their own mental health. So our connectors offer this non-judgmental and peer support, which is so vital and what families have said they really need. So I'm going to hand over to Tracy now, who's going to really share some further insight into the other community approaches, starting with Baby Steps.
Thank you, Mel. So Baby Steps is an antenatal programme supporting parents through pregnancy, birth and beyond. It was written by Angela Underdown and Sally Hogg for the NSPCC. And in Blackpool, we offer this universally. It's jointly facilitated by a Baby Steps facilitator who was originally employed by the NSPCC, but is now transitioned over across to the NHS Trust. And a health visitor also facilitates these sessions. We have a midwife who attends one of the sessions. So alongside the traditional education content, it also supports parents to think about topics such as bonding with their unborn baby, considering how they will manage relationship changes, keeping healthy and relaxed, improving their emotional well-being, getting to know their babies and recognising and responding to cues and communication. It also identifies the services and support networks for their community. Due to the COVID pandemic, we are offering this, instead of 6 face-to-face antenatal sessions, it's 4 sessions virtually and 2 sessions virtually postnatally. The Baby Steps facilitator offers a home visit prior to the course starting to introduce the programme, and then also meets the family and the baby once baby's born, helps to re-engage them ready for the postnatal sessions. To ensure that this service remains sustainable, we have trained the trainers in our trust who will then go on to train new staff as they come in. Thinking about the enhanced health visiting service, we're fortunate to have 8 universal contacts for health visiting service in Blackpool. So that includes an antenatal contact and 3 early infancy visits that tend to be around 10 to 14 days, 3 to 5 weeks and 6 to 8 weeks. We also offer a visit around 3 to 6 months, 10 to 12 months. We do an 18-month desktop review, and we also do development checks between 2, 2.5 and then 3, 3.5. Unfortunately, due to the COVID pandemic and current low staffing levels, sometimes these contacts have had to be offered in different ways, such as virtually or a variety of skill mix. The majority of health visitors have received training in delivering the newborn behavioural observation, and this is completed at one of the early infancy visits, and it's a flexible relationship building tool. And this provides parents, carers the individualised information about their infant's behaviour, promoting parental understanding to support them to respond in a way that meets their infant's needs. A few health visitors are also trained in the Neonatal Behavioural Assessment Scale, known as the NWC, and this is a more comprehensive neurobehavioural assessment, providing a rich insight into each individual baby. So if through discussions with the health visitors and the families, they feel that the parents would like more support with their relationship, then they can refer to the NWC health visitors. We also use the Solihull Approach, and this has 3 concepts of containment, reciprocity and behaviour management, and it's a practical way of working with families in a robust theoretical structure. We've been fortunate also in Blackpool to have a rolling programme over many years of the IHV Perinatal Infant Mental Health Awareness Training, and this is really ingrained into our practice. We now have a champion, a perinatal infant mental health champion within each of our health visitor teams. Some health visitors are also delivering behavioural activation, and I will talk to you more about this on the next slide. In Blackpool, we endeavour to work in a trauma-informed way. We are developing trauma-informed systems which support and enhance specific programmes provided, and this is underpinned by a trauma-informed workforce, such as health visiting practitioners who have that increased awareness of how trauma can affect children and adults, so they can avoid practices that could inadvertently re-traumatise those they are working with. Through working in a trauma-informed approach, the hope is to increase engagement with treatments and interventions that have evidence of reducing trauma and improving child outcomes. Currently, health visitors in a face-to-face antenatal contact will complete the ACEs inquiry questionnaire, and we envisage in the near future that if this has not been completed at this contact, that it will be offered at the early infancy visit. Thinking about behavioural activation, we have 3 health visitors and myself that are offering behavioural activation intervention as a research pilot, and we received training from Professor Heather O'Mahan from the University of Exeter, and she also provides us really valuable fortnightly group clinical supervision. Behavioural activation is an evidence-based treatment for mums with mild to moderate depression. We tend to deliver these sessions within the family home. Generally, the children are under 1. And this incorporates a guided self-help postnatal programme. And the goal is to help individuals rebuild a meaningful life and to regain functionality lost or reduced during depression. It also really seems to be supporting that parent-infant relationship and sensitivity that Karen talked about. So far, verbal and written feedback has been very positive, and one client recently saying that she felt she was in a really good place now. She felt the support was amazing and had changed her life for the better. She felt she'd had a light bulb moment and was very conscious about her feelings and how to understand these now, and she'd even managed to start a new business. Here on this slide, you can see that my role is certainly multifaceted approach, and the formal commissioning support that I have from commissioners for this role provides me with a solid infrastructure to undertake this work. And I'm really fortunate to have support around me from senior management, team leaders, Blackpool Better Start, as well as other local specialist colleagues. As well as offering support and guidance to colleagues, I'm also able to offer direct clinical work to a small complex caseload, often supporting parents with bonding concerns in the antenatal and postnatal period, and following assessments may need to refer to more specialist services. We have some really good examples in Blackpool of partnership working and being part of the weekly specialist perinatal community mental health MDT meetings. And also we have a weekly perinatal mental health meeting with myself, specialist midwife and lead practitioners from the IAP service and primary intermediate mental health. This provides us with a platform for joined up multi-agency working, supporting delivery of consistent, high quality and well coordinated care. When thinking about the strategic leadership development, being part of the national groups helps facilitate sharing of best practice across the regions and also supports the trainer role and strengthens the research base for this work. It's important to keep abreast of the national developments and share this to improve practice across the workforce. An element of my role is also contributing to the North West Coast Clinical Network and acting as advocates for families as we're in a good position to highlight gaps in service. It's a privilege to be one of the co-chairs of the Best Start for Life group and work with such innovative, enthusiastic practitioners all coming together to support development of emotional wellbeing services in the early years. Thinking about the training, even despite COVID's pandemic, we've still managed to offer this training in a multi-agency way to encourage that perinatal frame of mind across all services. We have foster carers, we have police, we have social workers, we have lecturers from universities all attending this training together, and it can really enrich the training. Future training expansions also includes this year raising the awareness of fathers' mental health and offering the IHV fathers perinatal mental health training, and also to deliver the health visitors the training for emotional wellbeing visits. We also offer video interactive guidance. Myself and some colleagues from the early help support team are offering this intervention. This is a video-based intervention that focuses on the best possible interactions between the carers, parents and the child in order to enhance the relationship and communication and build the attunement. Examples of when VIG is particularly useful is when parents are not sensitive to their baby's cues, or they feel that they've not bonded with their baby or child, or they would like to build more confidence when playing or interacting with their baby, or where they're struggling to manage the child's behaviour. In my experience, it empowers parents to feel more competent about their parenting skills. It gives them a new narrative about themselves and their children as they start to see the more positive interactions. Initially anxious, by the end of the first cycle, they realise that we're not there to criticise what they're doing. It's very much a strength-based focus, but we explore and discover what's working well, and they come out feeling more confident and the recognition of what's working and how they can improve. Our fourth community approach is focusing on engaging dads, our local dads. We know that dads are important in supporting their child's early development, which includes mental health. All of our approaches to engaging dads sits under the umbrella of the DAD strategy, which has 4 key focuses as highlighted on this slide: the workforce, the engagement, the peer support and the volunteering. The strategy serves as a call to action and a commitment from partners to ensure consistency of approach and promotion of key messages. I'll hand back over to you now, Mel. Thank you.
Thank you so much, Tracy, for that really amazing and insightful overview of some of our community approaches. And I wonder if our audience spotted you on that other slide with Colin, my colleague who leads on our engagement of dads. Tracy was often a guest on our Talking Dads show that we did during lockdown to help promote positive mental health for dads and their relationship with their baby. So thanks for that, Tracy. So I know we're drawing to the end of our presentation now, but I'd just like to share with you that, and I hope that we've given you a flavour of our community approaches to supporting infant and childhood mental health in Blackpool, and how this is a partnership approach and everyone's business. And we're always striving to understand the gaps and improve care for our families. So this slide just highlights and gives you a glimpse of what we're working on currently and where we're going in the future. So I'm really excited to share with you the fact that we're setting up a Blackpool parent and infant relationship service that will be going live this year. And that certainly has been a collaboration, an event, and real partnership working, and we couldn't have done that without that. And our Engaging Dads work, we're going to grow our peer support over the next year, along with helping our workforce to engage dads better with some training that we're offering. And we're scaling up our evidence-based programmes such as VIG and Survivor Mums Companion in partnership with our early help colleagues. So thank you so much for listening and engaging with our presentation today. We really love to connect with people and build new relationships. So if you want to get in touch with either Tracy or myself, please do so. And we're happy to meet outside of this event today. And we'd just like to leave you with this quote, that it's never too late, but earlier is better. So thank you very much, and we're happy to take any questions.
Okay, thanks for that fantastic presentation, Melanie and Tracy. That's really, really good. Lots of clapping hands there, which is great. The next part of the programme, Mel and Tracy, if you keep an eye on the chat, because some questions a bit about sort of the governance and also comments about, the really valuable role in terms of specialist health visitors and also the community connectors, which I think sound fantastic. And that's especially a way of thinking about a different sort of workforce, isn't it? Yeah. So what we're going to do next, we're going to go into breakout rooms. So you'll be automatically put into your breakout room. There'll be someone in there to facilitate, and after 20 minutes, they'll close and come back. So I think just in about 20 seconds time, I think Beth presses a button and we go into the breakout rooms. Then it's a chance to look at some sort of questions and some comments and meet other people as well. Okay, so if we go into breakout rooms now, and then we'll come back and we'll summarize and think about next actions. Okay, so is that okay, Beth?
Yeah, thanks, Neil. I will
Okay.
send people off now. So
Okay.
just bear with me, please.
Okay, thank you.
Oh.
Oh.
I wasn't sure.
how they'd be funded.
Hi there, everybody. Okay, so Beth, can you hear me okay?
Yes, thank you, Neil. Welcome back to the main room, everyone.
Yeah, so hopefully everyone got involved in their breakout sessions. I always think it's funny when it suddenly stops and we disappear. So we were hearing from Carolyn on Filed about what they were planning in Blackpool and in the coast as well, which was great. So the next sort of just 5 or 10 minutes is for me to summarize really, but maybe use a little bit of time to think of next steps, because that's been a theme in the breakout room, the session I was in, about what can we do next. So what we've heard today is we've heard from Karen about the evidence base and the overwhelming case for the importance of early intervention. She touched on the financial aspects of that, but much more, she used the word social capital, the idea of it's the right thing to do in terms of bringing change in children and young people's lives. We also heard from Helen, Claire and Michael about practical ways of working, which was relationship based, and the importance of trust. And Michael talked about the importance of love and the idea of creating relationships with people where they feel understood, and the importance of taking parents' perspectives on. We heard from Blackpool in terms of Tracy and Melanie about a fantastic bit of work, which was really innovative and evidence-based, which is one of the themes that we want to come back to over and over in this work, and the idea that we can actually use workforce really creatively. The community connectors really stood out to me. So we also heard about the range of sort of work we can do in terms of in the groups, and how it's important to find a way of connecting with others to look at what's the best way of working. So on your screens now, there's a breakout session. So hopefully there's lots and lots of work coming through there. I'm just looking at one-stop shop. People have touched on that, about co-location, collaborating, being listened to, and that's for users of service and parents, but that's also for frontline workers who can generate ideas as well. So if you just move on, Beth, for the next slide, please. So I'm just going to talk about how to stay involved and what people need. So the next for today for us, we're collating all the comments and looking at the main themes about moving forward for how do we develop this work. At the moment, nationally and regionally, it's about scoping and working out what's good practice, what's needed, and trying to work towards developing a group, which is the North West Coast Best Start for Life group. So we'd encourage people to join that. Okay, Beth, I'm not sure if an invite's going to come out for participants today, or they've already had that. The other thing is there is a pathway around parent-infant relationship pathway, so we'll share that, and if you can start actually reusing that and reflecting that in your area. Also, one thing is if you click on the participants, so we've had people from South Cumbria, Lancashire, the Cheshires, Merseyside, there will be people that you recognise the names of. So what we can do is to start the conversation. So there's been commissioners on the call today, so maybe make links with them. Also, we heard in the group I was in, we heard the idea that we need to find ways of linking more. So especially between health and social care, because there's so many overlaps of the work. So Beth's just said the details will be shared along with the slides and the pathway, and trying to those conversations. So if you recognize someone from the participants list, the next time you have a cup of coffee, email them and just say, let's have 10 minutes just to reflect on today. Okay. Also, we've Beth's asked people contact her directly if there's any issues coming from today or you'd like support with about moving this agenda forward. I think Lisa Nolan from Liverpool CCG commented about, you know, where do we do this work? Where do we plan this work? So again, this is the start of a conversation and start of a bit of work to start making links. I think sometimes we always underestimate the power of sort of ourselves in driving this forward. In the chat earlier, again, Ruth said about being audacious and bold in this work. So we know what can be really helpful. There's lots of examples there. So we should be you know, energized to actually contact people we've spoke to today and contact people we've heard about things and find out more and start going this forward. And I think the role of the network is to help pull that together and be a source of collating that. And again, you know, I'm struck by in developing today and the speakers, we've there's lots and lots of ideas, there's lots of expertise and lots of knowledge and also lots of good practice. And I'm sure, you know, I'm thinking of for, you know, maybe it'll be for a future event where we hear some other areas talk about things that they're really proud of and think they're making a difference, especially maybe in sort of slightly older children or in sort of specialist targeted groups who are particularly vulnerable, children, young people from minority groups or groups that are marginalized or harder to reach. That would, you know, so we'll be interested to hear that. Okay, so I'm just thinking about we coming up to end the day, so if I can finish with some sort of thanks for the presenters. I found them really useful. I you know, really thought-provoking, lots of ideas about what is possible, and there was lots of examples about how we make those sort of links. The practical examples about sort of clinical direct individual work illustrate what can be done. Okay, so and also I'd like to thank yourselves, because I know everyone's really busy at the moment and people have joined us. We've had up to 145 people today, and I think people have, you know, given that time. Yeah, I'd like to also thank the group who put this together, because I know we met a few times, and also Beth. In terms of Beth Luxmore, in terms of, I know that's been a lot of work for you today, Beth, so that's great, and you've kept us all on task and really organized. Okay, so thank you. So we've only got a few more minutes, so we've got hopefully that gives you a chance to have a quick cup of tea before your next meetings, or have a well-deserved break, because we've got to remember that, you know, although this is fascinating hearing about new work, we know it's we need to look after ourselves as well. Okay, so what I'm going to do is draw this summit to a close, and I look forward to meeting you in next sessions, and hopefully you've found it useful. So again, any comments or feedback, please get in touch, and if there's resources you want to share, that would be really good. Okay, so I'll wave goodbye and see you soon. Okay, bye-bye.